Welcome back, coding champions. All right, let's jump right into this. Welcome to part 81 of our 100-part CPC exam series. Before we get into the weeds, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Today, we're keeping the momentum going with part 2 of our anesthesia coding deep dive. And trust me, this one is packed with high-yield gold. So, are you ready to master MAC and sedation? Look, in this explainer, we are cutting out all the fluff, none of the textbook reading. We are focusing purely on the cheat codes, the exact strategies you absolutely need to pass the CPC exam. No time wasted, just the essentials. Let's do it. Section 1, Advanced Anesthesia Coding. We're broadening our horizons today. Moving way beyond standard general anesthesia and really getting into specialized sedation, pain interventions, and those tricky payer-specific modifiers. Let's quickly ground ourselves in the fundamental rule we learned last time, the anesthesia formula: base plus time plus modifiers. This explainer focuses heavily on step 3, those modifiers, and distinguishing between some very specific code ranges that the exam literally loves to test. Section 2, MAC and provider modifiers. Okay, this is where things get a little granular. Identifying the exact provider modifiers is a huge exam trap, but we're going to dismantle it right now. First, let's define MAC, which stands for Monitored Anesthesia Care. The absolutely crucial point here is that MAC is planned care where a qualified provider monitors vitals and administers sedation, but, and here is the key phrase you have to remember, they must be ready to convert to general anesthesia if needed. That right there is your conceptual anchor. Now, when you're coding for MAC, you're going to use specific HCPCS modifiers. QS is your standard run-of-the-mill informational modifier for MAC, but pay super close attention to G8 and G9. These are high-yield, payer-specific modifiers, especially when you're dealing with Medicare. G8 is for deep, complex, or markedly invasive surgeries, while G9 is for patients with a history of a severe cardiorespiratory condition. Make sure you memorize these. You also need to be able to instantly recognize the who did what performance modifiers in any test scenario. So AA means it was personally performed by the anesthesiologist. QK is medical direction of 2 to 4 concurrent cases. For our CRNAs, QX means with medical direction by a physician, and QZ is without. Just lock these performance modifiers in your memory bank for sure. Section 3, Moderate Conscious Sedation Rules. All right, here is a massive tip. Moderate sedation codes, which are 99151 through 99157, are actually found in the medicine section, not the anesthesia section. Please don't let the exam trick you on the location. Plus, you absolutely must distinguish who was providing the sedation. Ask yourself, is it the same physician performing the procedure or a totally different independent physician? If it's the same physician, you're looking at the 99151 to 99153 range. Different physician, use 99155 to 99157. Missing this distinction is a classic audit risk and, honestly, a guaranteed loss point on the exam. And listen to this. 10 is your magic number for sedation. You must meet a minimum 10-minute intra-service time threshold to even report that initial 15-minute moderate sedation code. So, if it's 9 minutes, no way. You can't code it. Always remember the 10-minute rule. Section 4. Pain management versus anesthesia. We need to rapidly separate surgical anesthesia from diagnostic or therapeutic pain management interventions. The big takeaway here is this. Interventional pain blocks for acute or chronic pain, like epidurals or somatic nerve blocks, are reported from the surgery section, not as time-based anesthesia. So if the provider is treating pain, look to surgery codes like 62320 or 6440. But if they're putting a patient under for a separate surgical procedure, then you're back in the anesthesia section. Here's another highly tested scenario. You have to know how to differentiate a labor epidural from daily management. The initial labor epidural code is 01967. However, if you are coding the daily hospital management of a continuous epidural drug administration, well, that's code 01996. Lock that distinct difference down, it's going to save you. Section 5. Crosswalks and multiple procedures. So what happens when multiple things are happening at once? This is exactly where the ASA crosswalk comes in. Think of it like a giant map. Step 1, you identify the surgical CPT code. Step 2, you use the crosswalk to map it to the corresponding anesthesia CPT code, based on the anatomic site. Just remember, anesthesia codes are organized by location, not by the specific surgical technique. And that brings us to a golden rule of anesthesia coding. You report only one anesthesia code, specifically the code representing the most complex procedure with the highest base unit value. Never, ever unbundle anesthesia codes for multiple surgeries happening under a single continuous anesthetic session. You choose the highest base value, add your total time, and that's the whole shebang. Section 6, Exam Cheat Sheet Outro. Wow, we've covered a ton of ground today. Let's lock it all in with a rapid-fire summary to really solidify this explainer. For MAC, remember QS, G8, and G9. For sedation, look to the medicine section, codes 99151 through 99157, and don't forget that strict 10-minute rule. Pain management blocks, head over to the surgery section. And for multiple procedures during one anesthetic session, report only one code, the one with the highest base value. You've mastered the fundamentals, but are you ready to actually put them to the test? In our next explainer, Part 82, we're diving into a CPC exam practice masterclass. We're going to hit high-yield anesthesia case studies, reimbursement formulas, and complex modifier dissections. You definitely won't want to miss it. Keep studying hard, and I'll see you in the next one.